My name is Nadia Lach-Hab, and I developed SeizNow, a highly accurate math model for rapid pediatric seizure detection. A little bit about me. I'm a rising senior at Washington Liberty High School. I founded a state nonprofit that does art therapy with over 300 hospital patients. I'm a student researcher at the University of Rochester, where I focus to integrate math, public health, and medicine alongside professors and undergraduate students. I'm an avid volunteer at the local addiction recovery center, where I created a school-wide addiction recovery plan and I train people on how to use Narcan. I'm also an independent researcher where I research psychosocial and biological factors that influence adolescent suicide, and I research the correlation between HIV vaccination rates and GDP. I want to major in neuroscience and become a neurosurgeon or a neonatal surgeon. I wanted to start off with the statistics. So, 1 in 100 children in the US have epilepsy, while 1 in 10 people worldwide will have a seizure sometime during this lifetime. But before we unpack this, what exactly is epilepsy and what is a seizure? A seizure is a sudden and uncontrolled burst of electrical activity in the brain that can cause changes in behavior, movement, feelings, and consciousness. And epilepsy is a series of seizures. It's a neurological disorder, but where some seizures have provoked and known causes, such as febrile seizures, where pediatric patients will get a seizure because of a high fever. Epilepsy is 2 or more seizures that are caused by unknown temporary triggers. Epilepsy is also more prevalent in children from low-income families, and these children often experience delays in diagnosis and treatment. This is where public health becomes very important in distributing equitable care for all families. So the issue with current detection is that pediatric seizures are often easily missed because they are non-convulsive and subtle. It is quite difficult to diagnose them. Even sometimes expert neurologists struggle with diagnosing pediatric seizures just because of the drastic differences with the types of seizures and the brain activity. However, especially in these low-income environments, diagnosis and detection requires expert neurologists, expensive equipment, and time that many hospitals, especially low resource settings, they just don't have that. So the consequences of this is a delayed diagnosis, mismanagement, and lifelong complications. These current methods rely heavily on these visual EEG scans that are reviewed by specialists, which is very labor intensive and therefore also costly. In underserved regions, neurologists are scarce, and even in the United States, many hospitals don't have 24/7 EEG monitoring, which creates deep inequities in who receives timely and accurate care. Therefore, the significance of this process is to address the major equity gap. Many underserved hospitals lack access to trained neurologists or EEG equipment. By using low cost and automated tools, we can expand access to care. This model also supports population-wide monitoring via wearable devices and hospital integration, and therefore places where traditional resources are often unavailable, AI and mathematical models can be used to replace that and therefore lower the costs of treatment. The objective of this experiment, again, was to develop an automated seizure detection methodology used in this EEG channel information. I also wanted to apply discrete energy quantities, which is a mathematical quantity published in a paper in 2025. So it is quite new and it hasn't been applied to medical research yet. Hopefully, this new formula will also account for the frequency variations linked to the brain pathology from different patients, so it can be accessible by a wide range of patients, regardless of demographic or neurological differences. I also wanted to, of course, enhance the ability to diagnose seizures and therefore facilitate early detection through early intervention. I started with 22 pediatric patients' data. So I accessed their EEG scans from the Children's Hospital in Boston, and I processed this in Python. The signals were then normalized and split into seizure and non-seizure periods. I then went and started to do my calculations. So I calculated the discrete energy quantities, their differences, graphs, minimas, maximas, and after I computed all of these values, I made a 3-layer neural network and I trained this neural network on the calculations that I did with the discrete energy. And I went and evaluated the accuracy of the neural network and I ran statistical tests. The results of this project were the bottom left-hand corner shows the non-seizure graph and the bottom right-hand corner shows the seizure graph, and their discrete energy values plotted over Hertz. So as you can see, the beginning of the non-seizure graph has a lot of this variability, whereas the seizure graph does not. So I wanted to input this into my neural network, which then computed a result of 87% accuracy and a test loss of 36%. The discrete energy values showed were all statistically significant. So this was applicable towards a larger group of pediatric patients. In conclusion, this discrete energy analysis was quite useful for comparing the seizure and the non-seizure EEG data. So potentially this formula is something that we can look to implement in AI and automation in the future, especially in medical research. This project was also developed at no cost, making it accessible to all, and there were no ethical or safety concerns. A strength of this experiment was that it also detected seizures within a 1-second interval. So currently, the accuracy of the current automated seizure detection mechanisms are around 70 to 80%, and this model had an accuracy of around 87%, and it did so only within 1 second. Some implications within the public health world is that epilepsy research is often overlooked. So we a lot of the times don't hear about seizures because a lot of the times they aren't fatal, but epilepsy itself is a very dangerous disease and it impacts many people worldwide. So public health approaches to seizures in youth are uneven just because of the lack of resources and personnel and even seizure action plans in schools and these environments, which leads to a lot of the minority children, so Black children and Hispanic children, are less likely to receive EEGs or care from a neurologist. So my goal is to collaborate with public health organizations to develop these open access seizure detection tools that can be easily integrated into a community with various clinics and pediatric ICUs globally. And lastly, I wanted to talk about the public health aspect of this experiment. So I wanted this project to be scalable, equitable, preventative, and policy-driven. And I hope to hit on all 4 of these. So I want to integrate this into public health clinics, be equitable as possible, so provide seizure detection where pediatric neurologists aren't available, preventative, so we can diagnose epilepsy in children earlier rather than later, which can prevent long-term cognitive damage. And then policy-driven, I want to focus on supporting AI-based tools in medicine. These are my references. And thank you so much for listening to this presentation. I wanted to give a special thank you to the people of the University of Rochester, professors, undergraduate student researchers, and staff. This is my contact information, and thank you so much for listening to my project.